Well, welcome, welcome, welcome. And this is all part of a series of lectures that we've been doing here at Heart of Hope Health, because it's really important to focus on the whole notion of prevention. You know, in other words, established medicine has gotten us into that mode of reacting to problems. So, don't get checked out, kind of wait until you hurt somewhere or something isn't working and then go see your doctor. And by then it's kind of like oftentimes so far progressed that, wow, now you need a lot of medicine and treatment. Well, we come from the opposite end of the spectrum. We want to ward things off. We want to prevent things from occurring. And you would think that established medicine would be really, really good at that. And there's science out there that would, if you really know where to look, it is out there to prevent a lot of disease processes from occurring. But there's not a lot of money in true prevention. So it's, even though people talk about it, they're not really implementing it as much as they could. And so that's the whole notion of why we came up with a series of lectures concerning transition to prevention. We want to teach people how to transition to that whole notion of true prevention. And just to give you a little bit of background, I'll give my story a little bit. A lot of the people who are listening to this know my story, so it's a little bit of old news for some people that are listening. But what I want to do is this video is also going to be watched by people who don't have any clue our background and who we are, and they're just interested in this MCG machine and this device and this technology. And so what I want to do is give you a little bit of my background real briefly, so you'll know how we're approaching this and who we are and why we're doing what we're doing. My name's Dr. Duke Johnson. I'm a true native here of Idaho. My great-grandfather homesteaded when Idaho became a state. So we go way back, as far as the history is concerned. I graduated from Coeur d'Alene High School, but my dad had gone to UCLA. So I went to UCLA undergrad, grad school, and med school, and started off as a level 1, level 2 ER doc in Southern California for years. So I know how to evaluate hearts. I know you do that every day in the emergency room. People coming in with chest pain, people coming in with difficulties and problems, and, am I having a heart attack? And so evaluating chest pain in an emergency room is something that ER docs and trauma docs do every day. And I did that for years, and so I feel very comfortable with this topic. And then what I did was I worked there for several years, and I had a 38-year-old male come in full cardiac arrest, and we couldn't revive him. And I thought, I've got one of the finest medical educations in the world, and somehow established medicine can't explain why this 38-year-old is lying dead on my gurney. And even though I never spoke with him, he changed my life, because I didn't want to spend the rest of my career patching people together who shouldn't even be there. I wanted to get on the other end of medicine, prevention, true prevention. So I started doing health risk appraisals in Southern California with a company where we'd go in and draw blood, and huge companies in Southern California. They draw blood, and then my role was to come in, explain the results, and then teach people how to prevent disease and slow down the processes, really a true preventive medicine program. I did that for several years. And one of our clients was the largest supplement manufacturer in the world. They had 800 to 900 employees on their assembly line. And so with Superior Medical Care, we saved them 25% on their healthcare costs. And they said, okay, we want to keep you forever, because they were saving a ton more than they were paying us. Okay, and true prevention does that. And so after a while, they said, well, why don't we move this out to our distributors and our customers globally? They had 3 to 5 million of them globally, because they wanted them to be healthy too and really understand the role of the supplementation and how that plays into prevention and true health, true preventive care. And so they did a trial program from Europe that was really successful. I had to gear my whole program for Europe, and it went really well. And they said, well, so they decided to build a multi-million-dollar center of optimal health, and they made me medical director, and I was there for 14 years. And they said, well, and we ran 17,000 people from around the world through our center. And I had to understand prevention, diet, lifestyle, healthcare systems, how religion and government impacted people's health, and then teach them how to prevent chronic disease. So I've got a real unique background and experience compared to most doctors. Most doctors, don't have that kind of a background and experience. And they said, well, we can't send everyone to our center. Well, Dr. Duke, come to our country. So I ended up teaching preventive medicine in 30 different countries around the world. So I've got a global historical view of medicine. I've got a view of medicine that very few people have. It's really an outside the box. And so it's a combination of, and I really understand the natural side from a scientific point of view. I mean, a lot of people who are in that natural side, they'll say, well, I hear this supplement or this herb might work well for this health problem. Let me give it to you. And then you leave with a sack of supplements. But my background is way more than that. It's I had to understand what is all of the literature and scientific validations concerning that herb, and what are the risks and the side effects, the positives and negatives. And then we're working at a formulation level. It was far more complex than most people who say they're in natural medicine can do. So I don't advertise myself and call myself anything other than the fact I've just got a ton of background there. So when patients come into Heart of Hope Health, I'm looking at them primarily, initially from prevention and what can we do naturally. And then I got to do some of the established medicine stuff for sure. But this is where we try to focus, because we want to allow people and teach people how to be free to take care of themselves. And so you're not dependent upon a system, and so that you can be healthy. I'd love to teach myself out of a job, sort of, really. I mean, have people be so healthy they know what to do, okay? So then, with that background, over my career, I've run across a number of modalities and machines that have come down the line that say, oh, this is a great way to assess people and test people. And I've evaluated a ton of different devices and machines over my career. And I've been in preventive medicine for over 30 years. And so I've seen a lot of things. And we heard not too long ago, about 6 or 8 months ago, about a multi-cardiogram, the MCG. And I had a feeling that this was of great solid science, and so what happened was we checked into it, and they said, would you like to have us demonstrate it at your facility? They're out of the East Coast. And we said, absolutely. So they were working with another clinic in the state of Washington, and they said, well, is there anyone else in the area that would be forward thinking like you guys are? And they go, yeah, Heart of Hope in Idaho. And so they came over here at the same time and demonstrated for us. And so what I did was, with this machine, I'll give you a little bit of background and we'll go through it a little bit, to understand that it is truly cutting edge. It's a paradigm change in thinking concerning heart and looking at hearts, because established medicine primarily focuses on the large blood vessels of the heart, okay? And so we call that macrovasculature, okay? But we all know that the heart and every tissue of our body has tiny blood vessels, and established medicine isn't really designed to be focused on the tiny blood vessels. And especially for women, a lot of their trouble occurs in the microvasculature, the tiny blood vessels. Now, there's a lot of times where people will go in and they'll have chest pain. They'll go into an emergency room or they'll go into a hospital and they'll say, I'm having chest pain. Well, if immediately they don't have elevated, enzyme levels like troponin, and they'll say, okay, well then let's do another test looking at your macrovasculature, your coronary arteries. And they'll say, oh, your coronaries are clear, go ahead and go home. But doctor, I've got chest pain. Well, it's not your heart, go ahead and go home. But then a few weeks later, sometimes then those same people will have a heart attack. Well, how did that happen with clear coronary arteries, right? Well, the whole notion of how we've approached cardiology, in a sense, has been focused in one arena and not necessarily focused completely on the heart. I mean, there's small blood vessels in our fingers and in our ears and in our eyes. Why don't we think there's small blood vessels we need to take a peek at in our heart, right? So that's where a cardiologist started going down this pathway about 20 years ago, developing this methodology. And you had to think outside the box, and there were a lot of algorithms involved. And I know that you've all heard about, AI, automatic intelligence, and there's good AI and bad AI, just like there are good salesmen and bad salesmen, good doctors and bad doctors. I mean, not everything is bad, right? And this utilizes really kind of what it was truly designed for, the good AI. So what they do is this gentleman developed this technique and this modality, and he he's got a private cloud, and he's done this testing on over 2 million people, 100,000 of whom have had angiograms, and all of the data concerning how long they lived, what happened, everything is entered into this database. And so when somebody comes in for a testing, AI compares you against the other 2 million people. It's not just some cardiologist looking at an EKG going, wow, I think that means this. I mean, not that cardiologists are bad, and I'm not knocking cardiologists. I have great respect for cardiologists, so please don't, I'm not going on that pathway. I'm just saying that, but it's time to kind of think outside the box, and that's what this machine does. It thinks outside the box. Well, we ended up being, when we saw it demonstrated, we wanted to purchase it, and we ended up being the first in the state of Idaho to have it, and only the second in all of the Pacific Northwest. So if you go to UW or any big center that you think would be great, they don't have this machine yet. There are facilities and systems on the East Coast that are starting to integrate it, and they're starting to integrate it into their emergency rooms. But the West Coast has been behind on it, but I don't need to wait till everybody's happy before I can make decisions. I've done this all along in my whole career. It's like, if I see it, science is there, let's go for it, okay? And and the machine is not inexpensive, and we actually had one of our patients call the next day after it was demonstrated and said, Dr. Duke, I hear that you wanted a heart machine. And I go, yeah, like, how did you know it? I still don't know how he knew. And he goes, well, Lord told me to buy it for you. How much is it? And I told him, and he said, I'll bring down a check tomorrow. So that's how we got it, okay? So I'm going to go through, now that you've got that big picture, okay, let me go through some of the details, and some of it will be a little bit of a review, but I wanted to give you that big picture so that you have a big understanding. And I also want to give you some idea a little bit about what we're doing here with Heart of Hope Health, because some of you may be customers and some of you may not. And so I'll just touch on that a little bit. We launched in February of 2022 as an alternative to traditional health care, and we're what's called a direct primary care, and there are two founders, Mariah and myself. And direct primary care, if you're not familiar with it, direct primary care takes memberships and works outside of insurance, and that allows us, and it works outside of Medicare. What that does is it allows us to make decisions for people not based on national standards, but or national mandates per se, but what we truly think based on the science we know and our history of medicine, what's best for you. In other words, it's customized and it's perfect, so that from our percentage, we're doing a customized care. And so everything we do is based upon the memberships, and direct primary care is actually spreading nationally. In fact, you can go to the American, I think it's the American Association of Family Practitioners, and on their website, it teaches doctors how to start doing DPCs or direct primary cares, because people are starting to think outside the box. Instead of everyone being treated the same way in every corner of America, let's expand outside of that box and allow the freedom so that you can be in control of your own medicine. And so we advise people and offer them advice, but ultimately we want to support the decision you make about your health care, not tell you what you should do with your health and your body, but give you advice and the freedom to make that, and then we support that, okay? And the system is actually much less expensive for many, many people, and most people don't know this. Once people get the idea that there's a tremendous cost savings, for most people, there will be a shift to this in the near future. Now, when you think of insurance, you think of doctor's visits and catastrophic stuff like, car wrecks and operations and everything, right? Okay. Well, what direct primary care is the office visit portion of it. Okay. And then there are organizations that are cost-sharing organizations like Samaritans, et cetera, where you pay them to be able to handle the catastrophic stuff. Okay. So a direct primary care plus a catastrophic or a cost-sharing organization is the same basically as insurance. And so we've got statistics from the state of Idaho, and it's shown here, and you can look this up, when the video comes out and go into greater detail, but, we charge like $100 a month for a primary and $75 for their spouse, and then $29 for children, but we cap it at $250 a month. So basically, you can have as many office visits as you want, the family, for $250 a month, okay? Now, anything that costs us anything, we pass it on. If we order labs, we've got to pass that on. If it's something that costs us money, but if it doesn't cost us much, like to put on a splint or do some suturing, we don't charge for that. Now, the combination of, and most of the cost-sharing organizations cost around $450 or $250, or $450 or $550 for a family a month. So the combination of the two is $800 to $900 a month. Okay, well, we've got statistics from the state of Idaho that show that the average family of four pays somewhere in the neighborhood of like $1,600 a month, and that doesn't count, deductibles and copays. Okay, so the average family of four would save $8,000 to $9,000 a year. Most families with this kind of a program. So most people I know of would be happy to save $8,000 to $9,000 a year, but we're so used to doing what we've always done, we just keep doing what we've always done. But sooner or later, people are going to realize, wow, there's something to this, and we've always kind of, throughout my whole career, I've always kind of thought ahead of the game. We just always looked ahead and kind of done things from that perspective. So now, where does the MCG come in? It stands for, multifunction cardiogram, and it's designed to look at the cellular level of the heart rather than the big blood vessels. We're looking at the tiny blood vessels and even the cells themselves, okay? And it took this gentleman years to come up with algorithms to be able to finally develop this, but the more information that he had, the more people that were entered into it, the more predictive that it could be. Because our interest is in true prevention, and some of these processes we can pick up 10 years in advance before they develop. So we can see signs of when somebody's going to get, heart failure or, some of these issues way before they start showing up. And that's where we are so excited about it, because we're ahead of the game. Now, I want to give some statistics for most of us. Some of these will be a little bit surprising for you. More than 659,000 people die of a heart attack in the United States every year, and over 300,000 people in the U.S. die of a sudden cardiac event every year. In other words, they had no previous symptoms, and then bang, they're dead. Okay? 1 in 4 deaths is cardiac related, and approximately 2 in 10 deaths happen in adults less than the age of 65. Okay, so a significant number of heart attacks are occurring in people. It's not just something that occurs in older people per se. And you're hearing a lot in the news about all of a sudden young athletes are dropping all over the world with heart attacks, and like somehow that's just something that occurs normally. Well, it hasn't been normal throughout my medical career. Okay, I changed my whole career 30 years ago because of a 39-year-old who had a heart attack, because at that time period, it was so unusual for someone in their 30s to have it that I changed my whole career. Now the news media kind of acts like, yeah, there's another teenager with a heart attack, no big deal, don't worry about it. Oh, he's fine, we'll send him back out on the field. Kids, I'm telling you, I've got a little bit more of a global perspective here. That's not normal, and that hasn't been the past norm, okay?
So are these numbers pre-COVID vaccine?
Actually, yeah, they are pre-COVID, right? Yep. And so most heart attacks occur with less than a 50% blockage of the large coronary arteries. Okay, now that's a hugely important point, okay, because we're going to look at the modalities of established medicine and what it is they can see, okay? But most heart attacks occur with less than 50% blockage, and 30% have no warning, okay? In fact, they're silent. We've known for years that 30% of heart attacks are silent heart attacks, so when I was in the trauma center or ER, I'd be holding up an EKG and I'd see evidence on the EKG of that person had a heart attack previously. And I'd say, well, when was it you had your heart attack? And they go, I'd never had a heart attack. A third of the time, people never knew they had the heart attack, okay? So a third of them are silent. We've known that for decades, okay? So the underlying factors begin 10 years before the heart attack actually occurs, and that's why this modality was created, to be able to pick up that stuff in advance rather than, oops, sorry, you're dead. You know what I mean? In other words, we want to be ahead of the game. Now, the multifunction cardiogram, it's supported by major medical studies that were peer-reviewed articles in 8 countries and 3 continents, demonstrating its effectiveness. It won the first place in 2017, the American Heart Association Heart Science Forum's Innovative Challenge Award. In other words, for its innovativeness, in 2017, even the American Heart Association recognized that this machine was amazing. And Samsung in 2017, with their Health Summit Challenge, gave an award for the potential to reduce healthcare care costs and major outcomes. Okay, so this has been around for a while, but the thing is that what's really interesting is that established medicine, as you'll find out, and I've got an article, I'll show you this, from the Journal of the American Medical Association. It normally takes established medicine 17 years to shift their normal practices. So instead of me waiting around for 17 years, we went ahead and got one of these machines, okay? And we had a patient recently who was just went to their normal cardiologist, and he already had an MCG scheduled in our office. And the cardiologist said, well, your heart looks good, but let's just go ahead and do a thallium treadmill to make sure that your heart is good. And so this gentleman told me, I didn't see his bills, I can't prove this right now, but I could. This gentleman told me that he had a thallium treadmill that cost $12,000. That his insurance company was billed $12,000. That's what he told me, okay? And so he came in here about 2 or 3 weeks later and got an MCG. And by the way, that doctor said, great, your heart's doing awesome. Don't see anything wrong with it. We'll see you in a year, okay? He came in here and we saw some significant findings that we needed to work on, and our test cost like $400, okay? So in other words, as soon as people understand that we can be ahead of the game and save them tens of thousands of dollars and lots of problems in the future, I think everybody in the world needs an MCG machine. And even more so, this picks up inflammatory, active irritation of the heart called myocarditis, okay? So anyone who's had a recent infection, or they've had recent problems, or they've had recent injections, and they go, you know what, I've got some chest pain or some chest discomfort, or I'm not sure, now I'm exercising, run around, and my chest hurts, they should probably have one of these tests, okay? Now, is this diagnostic? No, it's a test that adds knowledge. It's a test that gives us more information that we wouldn't have otherwise, So I'm not coming from this from the point of view of that this is all or nothing, but it adds information that we really kind of can't get in many other ways. And that's what the machine looks like. It's functionally like you're just getting an EKG. You lay on a bed in a gurney and we attach these to your limbs, and it does rhythm strips for about a minute and a half. We want to make sure we've got good, clear readings, and so it analyzes the rhythm in conjunction from different perspectives and enters all of that data in to the center, the AI that analyzes it. So it's not like we're injecting you with dangerous chemicals. There's no magnetism involved. There's no heavy costs. It doesn't take long. It's really simple and straightforward. So it's chemical-free, radiation-free, stress-free, portable. It's brilliant, in other words, okay? Okay, now, here are some really important statistics again. Each year, more women die of heart disease than breast cancer and lung cancer combined. Now, in the media, you'd think that the only thing that women die of is breast cancer, okay? But 1 in 5 females die of heart disease, while 1 in 31 die of breast cancer, okay? And there's a lot of money being spent in yearly mammograms and yearly ultrasounds and yearly biopsies and all of this kind of stuff. And we're not focusing on the 1 in 5. Now, I don't mean to knock cardiologists, because they didn't have this machine. They don't know, and I'm not blaming them. But what I'm trying to say is, it's time for us to now think outside the box. It's time for us to be in advance and to really start approaching these things. And many times women present with heart-related symptoms that don't mirror those of men, and so they're going to leave the clinic undiagnosed and in danger of major events and not know about it. And no current test other than this detects microvascular disease in the small blood vessels, which is very common in both men and women, but more so in women. It does detect small blood vessel coronary disease that is essentially invisible on our current modalities. Now, let me show you some statistics that, to me, this was very profound. Now, this is how current cardiac tests are being measured. These are the different modalities that are used. And so the first one here is the MCG. And then there's CT angiogram, which uses radiation and dye, so all of the others traditional cardiology uses. MRI angio, which uses magnets and dye. Stress EKGs, which is radiation and dye. Stress echo, which is magnetism and dye. And nuclear tests, which is, magnets and dye and nuclear, of course. Now, the MCG can pick up occlusions that are 40 to 50% in the major arteries 90% of the time. The other modalities can't. They can't pick up something that's 40 to 50%. So if you had one of those other tests done, like our patient, you're doing great. Go ahead and go home, see you next year. Okay, but it can't see it. 50 to 70% occlusions, like the coronary arteries are that blocked, we see it 90 to 95% of the time. CT angio sees it 82 to 92%. MRI angio sees it 74%. The remaining modalities don't see it. They'd say, go home, you're fine. A 70% blockage, we see 95 to 100% of the time. These two see it 82 and 54% respectively, and less than 40% of the time the others see it. Less than 40% of the time. And specificity, how specific are the tests? Very, very similar across the board there. How long does it take to do the test? 10 minutes to hours. Cost minimal, like we were talking about, to thousands, and how objective is the test? This is 100% objective because AI is really doing the reading, and it's comparing you to 2 million people. So it's not like how, did the cardiologist sleep well that night? Did he read the EKG real quickly? I don't mean to knock them, but it's like, it's time for us to rise above that, what we've been doing forever. Well, let me give you an example of what we've been doing forever. This was a study that just came out recently, in April 25th of 2023, from the Journal of the American Medical Association. It says it takes an average of 17 years for evidence to change the practice of medicine. The burgeoning field of implementation science seeks to speed things up. Okay, in a sense, there's established medicine is such a mammoth when you've got insurance companies and you've got hospitals and you've got billions of dollars and who you're paying and what sections of the hospital are you going to allocate funds for, and you have to plan and budgets in advance. And I mean, it is such a huge operation. I understand that it takes a while, right? But I kind of my point here is, do I understand how long it takes them to change? I do, to a certain degree. But I also think that should we all sit around and wait until they've all figured it out before you step up and take care of yourself? Probably not. Okay. And there are hospital systems around the country that are integrating this and starting to use it and integrating it into their ERs and all of this kind of stuff, and it's becoming more and more popular all the time. And so nationally, others are charging $500 a test, and in the first year, Heart of Hope Health we're charging $400 for the first test and any annual tests after that. But if we do a follow-up test in the same year, it'll be $300, because we've already did some of our first testing in February because we wanted to do some trial runs before we started talking much about it and advertising it and all of this kind of stuff. And we've now been able to do some follow-up testing and found that what we found on the first test, we implement some changes for people and what lifestyle changes to make and supplement changes to make, et cetera. And we've been able to show improvement. And so that's why it's good to do follow-up testing for people, for us to know that what we've recommended are going in a good direction. And then for you to see as well that we really are impacting and improving the heart functioning and reducing the risk as much as we can, and there's evidence of it. Okay? So here's, if you want to make an appointment, and this is our address and location, and do you guys have any questions? Yes.
Our cardiologist, it may not be as objective as
Right.
this. I got a kick out of that last column. Are they amenable to learning something new so far?
Well, what's really interesting is that people who are doing this on the East Coast, they've learned how to communicate with local cardiologists, and we're beginning to learn how to communicate with them too. And see, what I want to do is I want to work with the cardiologists so that we can work together. In other words, I've got a modality that, in essence, they don't have right now, we've had some people come through where their testing was so significant for their major coronary arteries where I said, you really need to see a cardiologist because I want you to do some of those larger tests. I think the larger coronary arteries are at a point where I know they're involved. I know which side of your heart. I know probably which artery is involved, and it's probably over 70% blockage. So let me point you in that direction, and I'm more than happy to give my report and give my interpretation to the cardiologist and say, based on this, I'm seeing early signs of this particular problem and that, and predictively, based on AFib, for example, there's a lot of people who just all of a sudden get AFib, and it's like, oh well, I have to be on blood thinners, etc. Well, this machine can pick up predictively that there's this much chance or a significant chance you're going to develop AFib unless we start turning things around. And so what I want to be able to do is work with cardiologists so we can work together as a team. And it's like for those things that I'm concerned that may be unstable or significant, or they might be very close to having an unstable plaque that could release, or they may be having significant, let's send you out for that testing. And then if you're stable, in fact, I was just talking to someone today, if you're stable, then we've got time. Let's work on what we can do to reverse these trends. So we're still going to be able to the established medicine are still going to be able to do their thallium treadmills. They're still going to be able to do their angiograms, et cetera, on certain particular people, but it's not going to be waiting until that person is in the ER clutching their chest and et cetera, et cetera. It's going to be a little bit more in advance, and then some of them are going to be able to push away and reduce the number of tests. So my goal is to be working with them and not competing with them or pushing them away, but hopefully educating them in that way.
Do you think at some point some of those modalities would disappear, being not as effective?
I could see where they would be less used in the future for sure, and that's probably part of the sluggishness that occurs in established medicine. Because if you're somebody who makes all of your income in a thallium treadmill, for example, you're not going to be super excited about this modality if you're making, if they're charging 10 grand or the system is making 12 grand. I mean, I'm just basing it on that one gentleman. I don't know what the cardiologists make, but I mean, my point is that there's going to be people who are going to kind of drag their feet a little bit, and I understand that. I mean, everyone's got to pay their mortgage, and they got to pay their bills and pay their debts and all of that kind of stuff. So I'm not trying to knock out or abuse anyone. I'm just trying to inform people that there is an option here, that we can be ahead of the game, we can protect you, and we can start implementing preventive medicine modalities. Because in our reports, I give a listing of about 20 things you can do naturally, and part of them are related to videos we've already made. So based on this finding, I recommend you watch this video, which will teach you for an hour and a half. And then let's set up an appointment, see how you're doing down that pathway, and let's recheck some of the blood values, because some of the things are because some of it is genetic testing, some of it is that we recommend and have done, some of it is insulin resistance. So let's implement this kind of a dietary program, let's integrate this supplementation, etc. And then we'll also check for where your insulin resistance is right now, and then recheck you in 3 months to see if we've been able to reduce that insulin resistance. We've been able to reduce some of that inflammation. Because I wrote a book, it was published in 2009. I actually understood this information in 2005, that chronic excessive inflammation is what underlies all chronic disease. Now, everybody kind of has heard that, and they kind of know that now, but when I wrote the book, I was the second guy that I know of who wrote a book on the topic. There was one person who beat me, and he had access to publishers, and he just wanted to splash his name out there of, I'm first, okay, but he hardly had any references. My book, I had to run it through this multi-billion-dollar corporation. All of the mucky-muck people had to read it, because even though it was my book, I represented them globally, and they wanted to make sure I didn't mess up and say anything bad. And by the time I got it through them, he had come out with his book, but I have almost 900 scientific references. And I just, in my career, I have had the opportunity to know some really smart, really successful, really brilliant people who are cutting edge type people. And so I really understand the concept. Now, there's a lot of people who say, oh, inflammation is bad, and then they recommend inflammatory stuff, which drives me crazy. So either they're stupid or they're trying to distract people in a wrong way, which drives me crazy. But we teach people how to reduce inflammation and how to do it appropriately and effectively. And then with that, by rechecking and seeing the improvement, then that's exciting. So it's not like we're just going, oh, there's your test, hope you do well. No. We've got everything with videos and instruction and follow-up testing where I know how to take people to the preventive medicine pathway, for sure. And we got lots of proof on that. Any other questions? Good question, thanks.
I'm excited because I'm doing the test this month, as you know.
Okay.
Yeah. Is there any prep before? I mean, obviously it's not like blood draw where you're fasting. So
Right.
Anything?
No prep at all. You just come in like you're coming in for an EKG. yeah, colonoscopy prep and no, yeah, it's just an EKG.
I just want to know, just knowledge is so important.
Absolutely, yes.
The column, all those columns, magnets was something you didn't have as to what this does not do. Are there magnets in that?
Oh, no, I know it. In fact, let me go back to it. The comparison, the different modalities. In the MCG, it's not invasive. We don't have to poke you with anything.
You say no magnets, so I'm being very...
Oh, okay, no, that's fine. No radiation, no dye, no treadmill. I think they ran out of room. There's no magnets either. Yeah. And I guess I could put no yucky yuck, no smell, no... Yes.
Just a follow-up question since you have that chart pulled up. So I think there was a distinction made when
this young lady asked her question about large vessel, small vessel testing.
Right.
So when you're quoting these statistics, is that just small vessel testing, or does that encompass all testing?
No. This actually is looking at comparing it to large vessel here.
So in other words, if you do the MCG test, is there a need to go do those traditional tests that a cardiologist would do?
Well, I mean, that's a great question. Is there a need to do the traditional tests that a cardiologist would do? What I would recommend, like personally, I mean, of course I'm going to be biased, but I'm going to see small vessel disease 10 years in advance of the big boys, the big blood vessels, okay? Established medicine is based on them because it starts in the small and then it goes to the large, okay? And so, I lost my screen here, so I'm glad it's up there. And so what we're looking at is literally at the cellular level. I mean, you know, in other words, they're looking at electron transport chain, and I mean, these algorithms this guy put together is absolutely brilliant. I mean, it's just so far advanced, it's like almost scary to a certain degree. And he just happened to be a cardiologist who understood this level of mathematics that very few cardiologists understand, and that's why he was able to assemble all of this. And so when we can look at that cellular level, we can look at the microvasculature, which translates to the larger, but the machine is also able to say, okay, is this only in the microvasculature, or does it involve large blood vessels? Is it local, or is it global? Is it left side, right side? So, I mean, in other words, I can get pretty darn close to saying, I know at least 30%, 50%, you know, there's an unstable plaque over on this side of the heart, we probably should do that major test. Because because when we're talking with somebody, it's not like I'm catching everybody early. I'm catching somebody who may be just about to have an MI, and I don't want to sit around and go, oh, well, I'll turn you around and I have no idea what's really going on where I can see exactly what's going on in that artery. So that's why when I get those kind of readings, okay, we better double check that I can buy some time to reverse you and it's not dangerous right now.
Thank you.
Yeah, great question.
Can it look at so small, can it look also at the cholesterol or plaque that's already there in the bigger areas?
Well, that was kind of what I was saying, and I probably didn't explain that very well. So what it does is that it does look at the microvasculature. In other words, you know, is it global? Is it like everywhere in the heart? Or is it localized to a part of the heart? So when it's localized to just one part of the heart on the left side or the right side, and then the numbers give me the degree of localization, when there's a substantial degree of localization on the right side of the heart, for example, you know, I know that it's probably the right coronary artery's probably got a significant plaque in that artery.
And that's reading that just by the beat of the heart and electrocardiogram, because it's not using dyes or magnets or anything. So how is it? It's his rhythm that he's come up with, and how is it actually doing it if it's not doing any of those other things?
I mean, see what he's done is when you've taken 2 million people, they have a slightly different beat and rhythm and electrical pulsation that's seen from different areas of the heart depending upon what was going on in that artery or this artery or that. And that's why a cardiologist couldn't read these. That's why it takes AI. I mean, if it weren't for AI, this wouldn't exist. Okay, but it takes a smart intelligence that the computer can take all 2 million people and then look at you, and wow, based on these 2 million people, I'm seeing the same rhythm over here and over here and over here that I saw in this group of people who had trouble with their right coronary. And by the way, they developed AFib later. And by the way, they had a genetic tendency. And by the way, they had some myocarditis. You know, I mean, in other words, I'm not, you know, I mean, so that's how it's done. It's really thinking outside the box. You know, if you only had 10 people, you'd go, yeah, the statistics aren't really good. But when you've got 2 million people and AI is doing it, and then it's like the more people that are added to it, the better it gets. I mean, it's only going to add more data this is going to make it stronger and more specific and more predictable. So that's how it does it. And see, when you think of an EKG, you think of an endpoint. It's like that electrical current that occurred in those 5 seconds or whatever, giving you a reading, and then the cardiologist has got to read it. This is it's a rhythm pattern in 4 or 5 different areas of the heart, and that are occurring simultaneously. So it's an electronic wave that's occurring, being analyzed from 5 different locations, that there are incredibly subtle differences that have to be fed in to be analyzed.
That's just compared to all those prior waves.
Mm-hmm. Right. So that's why it's so unique. That's how he could get to that cellular level, because you have to totally think outside the box. Because right now it's like, well, let me inject this and see if it's blocked. You know, I mean, it's like real time. But it's that cardiologist and that patient, okay? And I can understand how cardiology went down that pathway. I mean, you know, that's how I sort of think, you know, when a patient comes in, it's you and your hurt ankle, you know what I mean?
Well, it's all the technology that was available.
Exactly. It's like this is all based on what's happened now with AI. So now we can get away from, that's why we can get away from, you know, MRIs and magnets and injecting dye and radioactive material. In fact, I did this is an antidote story. With this multi-billion-dollar company, we were doing a program in Washington, D.C. I mean, they did them globally. I mean, every now and then they'd shift where in the world they were doing them, because these people had a lot of money and they were moving billions of dollars of volume, and so they wanted to keep all of their customers and distributors who were big real happy and real healthy, right? And so we would, you know, we had meetings in Monte Carlo, and we were at, you know, the Olympics in China, and we were, you know, in London. I mean, in other words, wherever these people wanted to go, oh, let's meet this year there. There were like about 280 people who ran through billions of volume. So, you know, you could put a lot of money into 250 people to keep them happy, right? And so we did a testing in Washington, D.C. One year they decided on Washington, D.C., and there were 4 really important people that I was concerned where their heart was. And one of the 4 people that I wanted to test, he told me before the test, he says, I just saw my cardiologist, and he said I had the heart of an 18-year-old. And I'm going, and the guy was like 70 at the time. And I'm going, oh, really? You know, there's no way in the planet this guy got an 18-year-old heart. I mean, I'm just telling you. And so what happened was we did thallium treadmills on all of them. We actually, you know, sent them to a local hospital and got an agreement with somebody, and the company paid cash and all of this kind of stuff, you know, to have all of these tests done. And this one gentleman, I mean, they said he needed an operation immediately. He should not travel anywhere. And you know, by God's grace, you know, he refused because he had a previous commitment. And I said, I'm telling you, sign right here that I told you you could drop in the parking lot of wherever you're going. And he said, honest, I promise, I'll be careful, I'll speak, I'll come back. And did it. He did have what we thought he would have. Well, this one in Washington, D.C., though, these people had gotten thallium treadmills. And so the thallium is radioactive, okay? And so the next day, some of the people were jogging by the White House.
Oh,
no. You can kind of tell what happened. They were stopped by guards who said, what are you doing next to the White House? Because we detect radiation. Okay, so what that tells you is that, yeah, it's a short-acting radioactive decay, and I'm not saying you shouldn't get, you know, a thallium treadmill. I've had a thallium treadmill, and I'm not glowing right now, okay? So again, I just want to let you know that these things are not without risks and side effects. I mean, you know, and so if we can be ahead of the game and be predictive and protective, I mean, that makes perfect sense to me. And that's why Heart of Hope of Health exists, you know, for exactly. Yes?
I'm thinking of the follow-up. So it's like having two test results. Does the machine compare them, or do you do that
The two test results?
over time? Yeah.
Oh, no, that's part of, yeah, in follow-up, that's the company does, the machine does a report, and then we've been trained on how to translate the report. So I'm the translator of the report that comes from them. And comparing, right, exactly. And in fact, the company wanted us, since we're the second in all of the Pacific Northwest, they were wondering if we would be, translators for them for other, locales that because they do conventions around the country and they want to know. So I don't want to call myself an expert, but we'll be real good at it real soon. Yeah.
Something, if the test is, good,
Yeah.
and there's like no urgent anything to address,
Right.
do you recommend it as an annual test, like part of a physical?
Well, it depends on the individual. I mean, in other words, if somebody were 25, 30, and they're taking good care of themselves, no, they wouldn't have to. I mean, because some people have had some things happen to them that it's worth doing the test just to find out. They've had some abnormal rhythms or something going on or family history or whatever. If someone had a completely normal test and they're older and they've got some risk factors, then yeah, I would probably do it. So it's going to be individualized.
So this is on the heart, they've taken all doing AI in the heart. Are they gonna be able to transfer that? I mean, obviously other organs don't beat like the heart
Right.
and have all that electric energy to read. Or are they gonna be able to do that with other organs like your liver, kidneys, lungs?
That's a really
What
good
else are they doing?
That's a really good question. All of his research has been focused completely on the heart, and there are countries around the world, like in South Korea, where they're doing, in Japan, they're doing a lot of research on this, and so that's when they talk about different continents around the world. They see it like I see it. They're ahead of the game, and they're going after this, and so everything they've done is they've put into the heart, because the heart is complex, right, and it's really fundamental. Now, will they take that and start doing electrical on other organs of the body? Probably not in the near future, but I could see, though, where, we are electrical beings. I mean, we do, every movement, there's an electrical impulse that's going down the nerve to move. I mean, for me to speak, it's electrical transmission from my brain to the muscles that allow me to speak. So we are electrical beings in an awful lot of ways, and so I could see where in the future it'd make a lot of sense to do that. I haven't heard him talk about it, but it makes a lot of sense. Okay, is that it already? Oh, wait, one more question. Don't turn the camera off. Okay.
So would there be certain markers where you would say, hey, I think we should run it, like high cholesterol or high blood pressure, or if you're seeing something on lab tests or things like that?
Actually, yeah. I mean, if someone comes in and they've got multiple risk factors, and I've taught what are the cardiac risk factors globally, and we've got them on video. I mean, one of our videos, I go through and teach what they are. If somebody has multiple risk factors, even if they haven't had any trouble at all, and you can learn what those risk factors are, yeah, it would make really good sense, to come in and get a test done for sure. Now, but honestly, I think because so many heart attacks, a third of them are silent, I wouldn't be able to give a criteria right now to say, oh, you don't need one, because there's so many things that have changed in just the last couple of years with, people getting infections and all of a sudden having abnormal heart rhythms. Well, what if they're 18 and they don't have any other traditional heart risk factors? If they're feeling chest discomfort that they never felt before, and because we're treating a lot of long haul COVID here, and I've had people who, one gentleman is like a running machine. He told me, I'd never watched him do it, but he told me he could run up 10,000 feet of elevation. And he's like a running machine, and he got COVID. He didn't get any treatments other than just no taste and smell for a couple of weeks and fevers and sick. And he started having abnormal heart rhythms within a few weeks after that. And he had abnormal heart rhythms for 21 months. He went to electrophysiologists. They were going to give him ablation, and he's thinking, how can I run up 10,000 feet and now I have to have my heart ablated? So we started implementing treatments for him to reduce that risk. Now, when he came in the door, would I want that guy to get an MCG machine? Absolutely. Testing? Absolutely. Because something happened. And even though by traditional measures, he would have 0 risk factors, but something happened that, oh man, he needs testing. And I think that's almost why almost anyone should go through the test once, and then we can, because there's so much that has changed so recently, so many people have gotten sick, and so many chemicals that are in our society and our food and our products, and so many toxic chemicals that we're exposed to. I mean, we've got risk factors now that, you know, that are inflammatory, you know, that aren't traditional risk factors, you know, that it's inflammation that underlies essentially all chronic disease. It's not, and what I found in my book was that all of those risk factors I was teaching for years cause inflammation, and that's why they're risk factors, okay? Well, there's a lot of things that aren't traditional risk factors that cause inflammation. So if something's inflammatory and occurred in someone's life, it's going to be accelerating heart disease, it's going to be accelerating cancers, it's going to be causing problems, and that's why we want to, you know, jump on it and say, okay, where is this person? Where is their heart at the cellular level? What do we see? Okay, now, based on them, let's implement these interventions to reduce that inflammation and protect them. And I mean, everybody's unique, and that's why I love the freedom of being in a direct primary care, because we're paid, we have half an hour, 45-minute, and an hour appointments. I mean, so in other words, we're paced, in between prevention and, in between ER and prevention, I had a family practice in Southern California with another doctor. And the two of us had over 8,000 patients. And so we were running through 30 to 35 patients a day, and that was the time of medicine where doctors were king, okay? The practice was named after my last name, okay? So, in other words, there weren't hospitalists and there weren't intensivists. So I admitted patients to ICU. I admitted patients to the hospital. I had to round on them morning and night. I've assisted in thousands of surgeries, okay? Most doctors don't do that kind of stuff, but that time in medicine, we did everything, okay? We were the king of medicine, really, honestly. And so we treated people the way we thought it was best for that patient. And it's like, well, that's my patient, that's what I think is best. Okay, doctor, okay. I mean, nobody questioned that kind of stuff. I mean, that was kind of the way medicine was 30 years ago, 40 years ago. But now it's completely different. And so what I can do is this direct primary care model. But see, at that time period, because of the insurance income, I had to see a lot of patients fast to cover my overhead. But now with direct primary care, my income is based on the memberships monthly, whether you come in or not. So then I can have half an hour, 45-minute, and an hour appointments. I can really get to know somebody, and I don't have to write a script and go, yeah, and what were you saying you had? Oh, here's the script, okay? No, I can sit down and say, well, tell me, what's going on in your life? What's going on with your health? I can really get to know somebody and then implement a personalized plan based on this DPC model, which is awesome. And then the videos follow up where people can watch their own video for, an hour and a half, like this video, and you can learn a lot. So I don't have to teach everybody everything. It's like, well, I'd recommend you see video number 3 for how to reduce inflammation outside of diet. And here's the diet we recommend based on 200 to 300 scientific studies and that I put together personally. And I lost 50 pounds myself because I didn't understand what they were doing to the food 4 or 5 years ago. I was just slowly gaining weight, and all of a sudden I realized, somebody's messed with the food. It wasn't like I'd become a glutton, but now I know how to avoid that and teach other people how to do it. And here's how you reduce insulin resistance. Watch video number 4. See, that kind of a thing. Yeah.
How much influence do you ascribe to genetics? You mentioned the word genetics once.
Yeah. No, that's a great question. What kind of influence do I ascribe to genetics? I asked because of my contacts with this multi-billion-dollar company, they could afford the top scientists around the world to come to a scientific advisory board meetings. And so they would, twice a year, they'd sit there. And I had the opportunity to get to know personally some of the most well-known scientists globally, I mean, in their fields. I mean, from a natural point of view. And I had the opportunity to speak with one of the top people at Johns Hopkins in prevention. And I said, I go, give me a percentage. You know, what percent is genetics and what percentage is lifestyle? Okay. And he refused to answer for me. I mean, you know, so I'm giving you his answer first and I'll give you mine. Okay. I said, come on, give me something. 40, 60, you know, 30, 70, 10, 90. I mean, come on, lifestyle, genetics. At the time, he refused to give me an answer. He goes, well, nobody knows. I mean, and in a sense, I have to admit, my answer is somewhat similar because it depends upon the problem. And it depends upon the frequency of genetic abnormalities, and it depends upon their extent, okay? It's much more of a complex issue because most issues have, you know, they might have identified, you know, a couple of genes, but there might be 30 genes that actually influence that health component. And some of them we don't even know about. So that's why he was safe to say, I refuse to answer the question. But my gut feeling, which has very little value, and I admit that, okay, but I would have a tendency to believe that that genetics is more in that 30% range and our lifestyle is 70%, and it's almost even growing because our traditional lifestyle that's average in the United States is getting so horrible, it's impacting us so much more. That's why obesity is climbing like mad. Since 1974, obesity has just gone up in a straight line, even though there's 1,000 diets out there and there's 1,000 million experts, and this is what you need to eat, and you need to have this, and you need to have that. They're not touching the growth of obesity. It has risen steadily since 1974. Well, why has it risen steadily since 1974? Because there's a lot of conflicting efforts, and there are a lot of ingredients that have been put into food, and a lot of things that we're exposed to that are causing it. So that's why I think it could be that our lifestyle is more in the realm of maybe 80% now and growing because of all of the stuff we're exposed to. I saw a statistic one time where they said that there's something like, I forget which governmental organization, I don't even want to mention them, if I knew, is the one that clears the new chemicals that are created. You know, they give their authorization of, oh, this chemical is safe for wide use. Well, there's something like they're presented with, at the time, they were presented with something like 100 or 200 chemicals a day, and they had like, you know, 20 people in the department. There was like no way in the world that they could possibly do a thorough analysis on everything they were presented with. It was just impossible, you know. So there's a lot of stuff we're being exposed to. That's why I think it's rising. It's lifestyle and rising. Any other questions? You guys are asking great questions, by the way. And if you don't know this, I can talk all night. So I've done a lot of it in my life, so I can do this for a long time. But for people watching the video, they're going, darn it, I wish you'd stop. Okay, so I should probably stop. But thank you guys very, very much. And if you have any questions, you know, contact the office and let other people know, because this will be good. They'll all understand this is ahead of the game, and it's really cutting edge, and it's paradigm shifting, and it's good. Alrighty? Thank you very much.